It's very stable. This is the analog that was created to work as amylin. It's called Simlin. The FDA approved it in the use for both type 1 and type 2s. And super physiological doses of it does not provoke hypoglycemia in normal subject. Basically, the meaning is, if your sugar is normal and I give you Simlin, it will not drop it. It only works when the sugar is high. It brings it down to a normal level. It does not drop it below. Insulin, on the other hand, could potentially cause hypoglycemia. And we do have patients, type 2s, that use Simlin only pre-meals and achieve excellent diabetes control in addition to their orals and maybe a long-acting insulin. It's usually well tolerated, no evidence of toxicity. It's really a manufactured hormone we make. No increase in frequency of lipid abnormalities, EKG changes, or any lab problems. The only one thing is nausea. We start low and we go up. We titrate according to the patient's symptoms. So the ABC of diabetes management, we strive to achieve a hemoglobin A1C below 7. We would like preprandials between 90 to 130 and postprandials 180. And I think in my book it's really 140, but this is what the American Diabetes Association published. And also, as you have all heard about the court trial that has not been finalized about the very strict control of diabetes might so increase mortality. We're still waiting to hear about this. We do not think that we should just like let the diabetes control get, we just let it go and we don't treat now. But I think it's the issue of achieving very strict control and balance it with hypoglycemia and other risk factors just to be careful. But I think the goal below 7 is still valid and we should all strive to do that. And of course the lipids, we have to achieve an LDL below 100, triglyceride below 150, and a good cholesterol of HDL above 40. This is not available in the state, and of course I had a couple of patients ask about islet cell transplant. Where are the futures going? Initial reports were overly optimistic. There's the Edmonton trial. I was involved in NIH with NIH. We had a few patients who had islet cell transplant. Unfortunately, the cytotoxic medications that they used to suppress the immune system in order to accept those cells, they were by far much more damaging and causing major problems, and therefore they were stopped. And we required a very high dose of immunosuppression, and we needed like three donors in order to achieve like the transplant to be effective and people can stop the insulin use. And most of the patients in this trial, they did still need insulin, maybe to a lesser extent, but nevertheless they still needed insulin. So, just summary, the biotech, you all hear about it, works for certain individuals, also certain individuals. The sustained release version of the DPP, which is another group of medications to inhibit the degradation of the glucagon-like peptide, is called Genovia. This is in the form of a tablet. We use it now frequently in type 2s. We'll broaden the use of these agents, new agents. Simlin is useful in the motivated patient. It's an injection, but really with the new pens and the new needles, really painless, and people like it, and they seem to be doing well with it. Istrocell, as I said, is still experimental, and the anti-cannabinoid receptor, it caused unacceptable psychiatric, therefore it's not really yet approved in the United States. We should be aggressive. Most of us have to understand that especially type 2s will use more than one agent. A combination therapy is the way to go, and improved glycemic control regardless of the hemoglobin A1C being below 6, below 7, or so. It's all going to cause decreased microvascular and macrovascular diseases. And anything above 7 indicate patient may benefit from insulin therapy, and timely initiation of insulin is very important, and try to mimic physiology is another. And I thank you. It's too long. Probably you're bored listening about diabetes and obesity. don't know how to turn it.
Any questions?
Too complicated, was it? I tried. I really tried.
We're going to have a quiz to get the parking.
Too complicated. Actually, it's not a matter of ideal. It's approved for both type 1s and type 2s. If we have a weight issue, and as I said, both of them naturally secreted by the pancreas. We always give insulin. Insulin causes weight gain. The other one, actually, when you give it, it helps to bring the glucose down without this associated weight gain. And many of us, type 2 specifically, very concerned. I mean, it's like a vicious circle. They gain weight, there is more resistance, more insulin. So actually, it's very good, very well tolerated. Most of the patients, they might have nausea the first week or two. We titrate. The dose is different between type 1 and type 2. Type 2s, we start at a 120 microgram, go up to 160. Some literature even we tell them to use double dose, like they leave the needle and they give twice. The type 1s, they start 15, 30, 60, very smaller doses. It's all it's like complementing. It's like two pieces of a puzzle. They just, together they work beautifully. Correct, it is. They need less, and they're very much more sensitive. Much more. It's like, type 1s are always sensitive. The other people, they are resistant and they need more. Go ahead. Absolutely. We do use it in type 1. Yes, absolutely. Absolutely. And it decreases the effect of the insulin hypoglycemia, because when you're normal, it does not cause hypoglycemia. We had a few type 1s that they don't use much they only, they have some residual function. They use much less insulin and the Similan, and together they achieve better without the hypoglycemic effect and the weight gain, which everybody is concerned, even type 1s.
One more question, please.
Yes. You can do that on the pump, absolutely, yes. We have patients who use it on the pump, type 1 and 2.
Thank you. That was great.
You're welcome.
We're going to take another break. At 5 after 3, we're going to reconvene here. 5 after 3.
How do you turn this off? I've been trying to do this. It's like on stop. It's not moving.
Huh.
I know, I tried. Oh, the thing.